On the first day, as a Locum Consultant Anaesthetist, I attended a multidisciplinary team meeting where I was greatly impressed by the surgeon's in-depth understanding of both non-surgical and medical aspects of patient care. I also appreciated the insightful contributions from the two anaesthetists, particularly their input on case clarifications and decision-making. However, I silently disagreed with one decision regarding the cancellation of a patient who had failed to stop dapagliflozin 3 days before surgery. I later shared my concerns with both anaesthetists. This led me to reflect on the broader issue of whether surgery should proceed in such cases. Is this a clear-cut decision, or is there room for differing perspectives? In the start, there was a word, and the word is glucose-produced energy is our survival priority. If it goes wrong, as master insulin goes missing or weak, diabetes mellitus develops. Conventional wisdom applied insulin replacement or enhancement as the recognized therapy. Of course, treatment could have included anti-glucagon therapy, which would have been impossible at the time. As time passes by, we kept ignoring the fact that total pancreatectomy diabetes is not necessarily associated with poor glycemic control. Conventionally, we continued, and glucagon was set free only to learn that most of diabetics are potential diabetic ketoacidosis projects. As flourishing stress hormones, including glucagon, close in on vanishing insulin, shifting towards fat-produced energy. Now, as liver capacity to oxidize fatty acids is exceeded, ketone bodies accumulate, resulting in more than 12 anion gap metabolic acidosis. That could prove fatal. So the culprit in DKA is higher glucagon to insulin ratio. DKA incidence in 1,000 patients years. Please note a zero is added to the percent symbol to make it per thousands. So it is 4.6 to 8 in type 1 diabetes, while it is as rare as 0.16 to 0.76 in type 2 diabetes, and insignificantly higher with sodium glucose transport inhibitors therapy. Now, the little amount of insulin with type 2 diabetes is responsible for such rare happening of DKA. Sodium glucose cotransporter 2 inhibitors, or SGLT2I, are the newest oral type 2 diabetes drugs and are increasingly being prescribed since 2012 or 2013, according where you are. They block sodium glucose cotransporter 2 in the kidneys, inhibiting renal glucose reabsorption and promoting glucosuria. This confers glycemia-dependent control, not leading to hypoglycemia. Beneficial effects on the cardiovascular system were discovered that expanded highly its indications. Away from type 2 diabetes, it's used for cardiorenal protection in heart failure and also for weight loss. We agree that DKA develops secondary to high glucagon-insulin ratio. Following hyperglycemia of type 1 diabetes, mainly higher than 14 millimole per liter, metabolism shifts to lipids instead of carbs, with accumulation of ketones and metabolic acidosis with bicarbonates usually less than 15 millimole per liter and an anion gap of more than 12 millimole per liter. However, with type 2 diabetes, things look different. DKA could happen before glucose reaches the cutoff point, less than 14 millimole per liter, that originally defined DKA. Hence, the confusingly misnomer of euglycemia DKA. And more accurately, it should have been said, DKA was lower than anticipated glucose levels, which makes early diagnosis difficult at the end of the day. SGLT2 inhibitors promote a shift from carb to lipid metabolism, as lowering of plasma glucose will lead to lower insulin levels and increased glucagon secretion. Hence, increasing glucagon-insulin ratio as a rehearsal for DKA. Severe stress could increase such risk, which includes surgery, especially with severe type 2 diabetes, hemoglobin A1C more than 8%, liver disease, insulin use. And any dose reduction comes with higher risk. Obesity, bariatric surgery, and emergency operations. Pre- and post-operative hypovolemia, post-operative inadequate nutrition, infection, sepsis, and glucocorticoids use would all definitely increase such risk. Canagliflozin was first SGLT inhibitor to be FDA approved in March 2013, followed by dapagliflozin in January 2014, then empagliflozin in August 2014, and finally ertigliflozin in 2017. Nothing funny about such history and years. However, we are going to witness confusing guidelines which all are not evidence-based, but rather based on either small series of cases or experts' opinion. So in 2020, guidelines were continuous day case surgery. In cases of minor and major surgery, stop the morning of surgery and restart with food. In 2025, at last, anesthesiologists came to the stage. Anesthesia Patient Safety Foundation re-examined current recommendations. FDA, stop for 3 days for the first 3, and for 4 days for the 4th one, based on series of cases and longer pharmacological T1/2 than elimination 1. Nearly 75 cases. 57 of them were reported with dehydration and insulin use. Some other American colleges stopped the medications for 24 to 48 hours prior to scheduled surgery, based on expert opinions and small number of cases. But one may wonder, didn't they ask about FDA cases? Anyway, I don't know how it is played in America. In emergency surgery, we carry on carefully. Perioperative care should focus on the prevention of dysglycemia in order to improve outcome. Monitor glucose, ketones, anion gap, pre, intra, and post-operatively. Stress-free anesthesia is must, local or regional. Careful pain management. Intraoperative insulin infusion to maintain a lower ratio of glucagon to insulin. Fluid balance optimization is essential, so is early mobilization. Continue monitoring at advanced level of care until adequate nutritional intake. Scheduled surgery with SGL inhibitors inappropriately held. Rescheduling the case is not the immediate answer. Look for DKA risk factors. Now, low risk factors besides regional anesthesia and expected adequate nutritional intake post-operative could allow surgery to be carried on. Otherwise, reschedule. But if cannot rescheduled, treat as emergency. One final word. Pass them the verdict, not guilty as charged. If SGL inhibitors are given for non-diabetic indication as heart failure, hypertension, or weight loss. Very obvious reason. These patients are not projects for DKA as their glucagon-insulin ratio is not at fault. Now, what happens if type 2 diabetes develops heart failure and given SGL inhibitors? Well, they would serve the heart as well as diabetes itself. Just imagine stopping it for a period of time may topple the balance unfavorably for the heart. You don't like that, do you? Then the verdict is guilty as charged, risking DKA, but for good reasons. So continue medications with all necessary precautions, exactly as in an emergency situation. Thank you all.